Yeah, sorry. Um, I have a question for Dr. Shazli. So, you've been doing bone ablation. I was wondering, what is the biggest lesion that you ablate with microwave?
Okay, the important thing for bone ablation is the size of the nidus rather the comprehensive or total cross-sectional area of the lesion. So if we target always the nidus, which is usually less than 2 centimeter in size, and most of the time it's 1 or 1.2 or less than 1 centimeter. So we target the nidus rather the surrounding sclerosis. So the target is achieved with RFA or microwave both. So it is not the size of the whole lesion. This is the size. It is the size of the nidus that really matters, and we have to target that.
Thank you.
I have one question. Jamshid, do you have any idea or can you remember the recommendation of hydrodissection for thyroid? Which fluid professor was using? I mean, dextrose or it's saline?
That's a really good question, and I think it depends on the modality that's being used, whether you're using RFA or whether you're using microwave for thyroid ablation. I think what Professor Shu was describing was saline, but it's unfortunate that Professor Shu is not here with us to answer that question himself, because I think if I remember correctly, Professor Shu is using microwave ablation for thyroid nodules, and he was talking about the various techniques, the moving shotgun technique and the transisthmic medial to lateral approach and all that. But I think if I remember correctly, I think he mentioned that he sometimes uses a bit of saline for hydrodissection. I'm not sure, so I might be making that up. But obviously, if you're using RFA, you don't want to use something ionic like saline. In that case, you have to use dextrose.
I have one more question for Dana. Uh, can we use the thyroid ablation or liver ablation needle for bone? This is one of the questions which usually people ask from us, and we don't have any clear-cut answer for that because there is big difference between the antenna of bone versus soft tissues. But if we can do it with the thyroid needle or with the liver ablation needle, we should do that because the bore of the bone microwave needle is the gauge is very thick. So, do you have any idea?
Well, actually, it can be used as long as it's good for puncturing and all that. And for thyroid, for osteoid osteoma, as far as we know, we have some users that they are using the 16 gauge antenna with 3.5 millimeter active tip for the osteoid osteoma cases lesions. But for bone tumor, we don't hear much about the antenna selection, but theoretically it can be used. Like the antenna that you're using for liver or lung ablation, it can be used for the bone tumor
Okay,
ablation.
thank you.
Just a quick question I have as well, because I've got a copy of your brochure with the different needles, and I've noticed that you've got ceramic tipped and metallic tipped needles. Um, uh, what's the difference, and how do you recommend one over the other?
Oh, well, actually, most of the cases, it depends on the doctor's preference. The ceramic antenna, it can be used under slight higher ablation, like ablation output power, and but metallic antenna, it also has its own advantage. Some doctors they just prefer using metallic
Robust.
antennas. Yes, and actually, right now we have a new model of ablation antenna, which we call it high sphere, and it is also a ceramic antenna. It comes with more spherical ablation zone because in some cases doctors prefer much spherical ablation zone. So, uh, like in their function, in their working mechanism, there is no much difference between thyroid ablation, ceramic antenna or metallic antenna, but since it can be, ceramic antenna can be used with a slight higher power, sometimes they prefer using ceramic antenna.
Yeah, I have some feeling that I think ceramic antennas more are for more precise and extensive in delivery of the energy, and they have some advantages over the metallic antennas. I think, but
Yeah,
due
I
to
completely agree. But I have some colleagues who there's this general feeling, completely subjective, that the ceramic antenna is a bit flimsier and easier to break, and for that reason, some people don't like the ceramic antenna. But I completely I agree.
I searched for that when it
All right,
occurred in
because
Europe.
I'm just
Yeah,
speaking subjectively.
yeah, it occurred only once in one
Right,
hospital, and it
right.
might be some fault from the performer, primary performer, or some defected
Yeah,
piece maybe.
Well,
it's an
towards
old
the
wives'
intended
tale.
use and its ablation protocols, we have very strict recommendations, and normally we would suggest our users to follow the manufacturer's suggestion regarding the ablation protocol. Just to be able to have a good ablation with safety and curative effect. That's, I think sometimes, maybe things happen.
Right. I don't know if there's no more questions. I think we're probably approaching about the time that we were going to close the session, Dana. I don't know.
Yes, we're, yeah, it's coming closer.
Coming closer.
Okay.
So I don't know if anyone else wants to has any burning question or anything they want to discuss. I think one theme went very quick. I mean, probably 30 seconds. I don't know if you have much time left. And it's important that none of these things are in isolation. So there's a broad, we treat things surgically, we treat things with ablation, and there's also the option of like Sahid actually went into quite a lot of detail about um, uh, radiation therapy and gamma knife and all of these things. So we really need to be cognizant of all the various things in the armamentarium so we can have a meaningful result for the patients.
Dr. Anwar, what diseases are you using the microwave ablation at in your center?
So we've used microablation for livers quite a lot, but we're in the process. I think we're starting a thyroid ablation program, and we've kind of got a two-pronged approach. We've got both an RFA mechanism on hand, and we're keeping microwave as a backup as well. So we'll see how that goes. We do most of our bone ablations with RFA, particularly the osteomas. And unfortunately, we don't have cryotherapy in Pakistan. But in the UK, we used to use cryotherapy for renal lesions, mainly, just because it was, the ice flow was easier to see and that was more fun spinning. But I think these things all come in swings and roundabouts, and I certainly think that microwave has a bright future, and there's a lot of things that we can do with microwave as well.
Then I have a question, and what is the experience of our interventional radiologists and surgeons in China regarding ablation of the subserosal fibroids? Because it is one of the areas where, this is one of the area where, especially the unmarried women don't like to get hysterectomy done, and we can't offer uterine fibroid embolization because it is subserosal in position. So what is the local experience?
Actually, doctors in China, they're quite comfortable with the microwave ablation of the uterine fibroids. IRs and also the gynecology department, they're doing with the different approaches, percutaneous or transvaginal. So I would say it's quite mature technique in China, and I think we also tried to do similar cases in different countries, but so far the result, maybe they're not very familiar with the procedure. I'm not sure, but it's not going as well as in China. But we hope to, promote this ablation technique in different places, because in China we are having really good results with microwave ablation on the uterine fibroids and adenomyosis.
Jamshed, we can start a combined study, or at least we can think of some future project with the CCMA for subserosal fibroids, especially because it is a challenging. Yeah.
Challenging area. Yeah, no, definitely. Yeah, no, I think that's a very interesting application and one to watch. To watch the space, and yeah, certainly I think we need to, moving forward, kind of consider all these options.
I think our time is up, so the discussions are going really great.
That was a great session. I think everyone really enjoyed it, and it was quite interactive. We got to ask questions and discuss things and mull things over. So thank you so much for giving us this platform and this opportunity.
Thank you for joining us. Thank you for supporting us. And I mean, if there is any more questions that for Professor Xu or any other doctors, any other panelists, you can just send an email to us so that we can get the answer. This is just one session, but I'm sure the cooperation, the communication regarding this academic issue, it should go on.
Sure. Thank you.
Thank you for the excellent presentations and the discussions. So have a nice evening.
All right. Have a nice evening. Thank you.
Thank you. Bye.